So the next generation sequencing will help us at this time to make some decisions on patients. For example, patients who have BRCA mutations or PALB2 mutations or to that matter DNA repair defects, maybe those patients will benefit more with some of the drugs we use. And that's a way, for example, we're doing it for BRCA mutations, but I'm sure that this will extend to the other DNA repair mutations where DNA damaging drugs like platinum compounds can be used, but also using PARP inhibitors as maintenance treatment in some of those patients. Certainly, if we have some markers like in a patient like microsatellite instability or tumor mutation burden, that might be another reason for us to use, for example, immunotherapy. But also there's importance because there's a fraction of the patients who have KRAS-wild type. So just to go back and think of most patients with pancreatic cancer have KRAS mutations. I would say 90% or so, 85 to 90%. And historically, we didn't have a drug to target the KRAS. Now we are drugs or drug studies or development that would target the KRAS. So that's another good reason to really get those patients and send them to the clinical trials. But in those patients who have RAS wild type, KRAS wild type, within that group, which is 10%, which if you multiply 10% by the number of patients within a country or globally, and I thought when I give my talk, I think like 60,000 or more patients in the world will be KRAS wild type. Those patients also can benefit from looking into personalized treatments because there are some targetable mutations and gene fusions that are enriched within that population of RAS wild type. Just to give you an example, 2 weeks ago I started a patient of mine on an FGFR inhibitor. Now, we don't use FGFR inhibitors in pancreatic cancer. We never tested that. But this patient happens to be a RAS wild type, and the patient has FGFR fusion. So I started the patient on treatment. Again, if you don't look for it, you won't find it. So that's really a very important aspect. When it comes to liquid biopsies, the liquid biopsies can also serve a similar purpose like we do for the tissue NGS. And the liquid biopsies in pancreatic cancer are important in a way because, unfortunately, given the small sample size of tissue that we get, sometimes we don't have enough to do NGS on the tissue itself. So liquid biopsy is another way of looking at it, although we don't always have exactly the same results when we do both in the same patient, but in the majority of the patients it will help. And the other option obviously would be to do a new biopsy on the patient if your original diagnostic biopsy doesn't have enough tissue for you to do the NGS, then you have to do another biopsy. But doing a liquid biopsy is one other option that you can do in those patients.